My name is Bryan Williams. I'm from University College here in London, and my guest today is Felix Mahfoud, who's from Homburg in Germany. And we're going to talk about the use of device therapies in the treatment of hypertension, particularly resistant hypertension. Felix, where are we at today with renal denervation, do you think?
You know, HTN-3, so the pivotal US trial that was published last year in the New England Journal, showed no benefit of the procedure in the way it was carried out compared to optimized medical therapy in the first sham-controlled trial. And there were key learnings from that trial which directed us to a different way of assessing sympathetic nervous activity and also a different way on how to do the procedure actually in the study population.
I mean, do you think that the problem with the trial was primarily because the procedure wasn't done effectively? Is that?
There were multifold problems with the trial or confounding factors, and the investigators also published that very recently in the European Heart Journal.
Yeah.
Catheter design might be an issue. Operator experience, 111 operators did 350 procedures. There was no strict treatment protocol for those procedures, and in the way it was carried out, it might be less effective than according to revised treatment protocols could be. So we learned that the anatomy, for instance, is very important. That's the ultimate target. The renal sympathetic nerves are getting closer to the lumen in the distal segment of the artery, whereas in HTN-3, the treatment was only delivered in the proximal or mid segment, so there was not special attention paid to the distal segment or the branches of the artery.
So you make some points that actually, although the trial didn't demonstrate a benefit on efficacy versus a sham procedure, that you've learned a lot about how to do trials in future. So what kind of trials are going on now? Because clearly this kind of approach to treatment needs a positive result somewhere if it's going to get adopted.
Absolutely.
So what will the next trial look like?
So first we did a lot of preclinical work, we optimized the technology and the technique. We identified.
So what have they done there?
So what we did actually is we investigated different approaches. We treated the proximal segment, we treated the mid and the distal segment, and went into the branches and were able to show that the variability in treatment effect is much lower whenever you enter the branches. So in the distal segment and the branches, where the nerves are getting closer, are more accessible to RF technology, variability is much less. First. Second, identification of the right patient population. We have seen that patients with very stiff arteries, those with isolated systolic hypertension, with high pulse wave velocity, high central pulse pressure, that are those patients who are responding less to renal denervation. And of course, and you have seen that in HTN-3, 50% of the patient changed medication throughout the study period.
Always a challenge.
That is a challenge, created so much noise, variability in treatment effects again. So what we need is a purer population of hypertensive patients. And
I would agree with you, because I think it's not about whether you get the defining result in the right population in terms of future treatment. It's about proving that it works, and maybe actually doing a study in a population that are not on treatment at all might be the way to do that, because you'll at least get an unequivocal answer, because you can't have the confounding of
It's interesting because retrospectively, colleagues are asking, why didn't you start with drug-naive patients? I mean, we're talking still about an invasive procedure, and we started with the sick of the sick, the very resistant hypertensive patient population. Although this is a very difficult patient population, multiple drug, all the challenges in patient behavior, adherence might change throughout the study. So what we're doing now is a two-phase study design. Actually, we're assessing renal denervation in an off-medication patient population.
Really?
Yeah, interesting approach that was kind of proposed actually by the FDA. So they wanted to see that renal denervation is lowering blood pressure without any effect on influence on antihypertensive drugs. So there's one patient population, and on the other hand, we'll go to patients on a strict fixed dose regimen of antihypertensive drugs, 3 classes. Not maximum tolerated, and there are no changes allowed throughout the study period.
So basically a much cleaner design,
absolutely,
including patients who are not on any treatment, so we will get that out. So just briefly, when can we expect the result of that?
Studies are conducted, include the first patients now. Protocols are approved by all regulatory authorities, European.
1 year, 2 years?
I think 1 year.
Wow, that's
1
gonna
year.
be great.
Hopefully end of
well,
next year
maybe we'll have
get
you
it.
back next year.
Yeah,
and you can tell us
hopefully,
the
to chat
results.
about it.
Okay.
Yeah, of course.
Well, thanks, Felix. That was really great. So maybe if I can just summarize what we've heard, there is still a lot of activity going on in terms of new trials with renal denervation, and very interestingly, these trials have taken some learnings from the hypertension, Simplicity Hypertension 3 trial, are going to be adopting new features, including treating treatment-naive patients. In addition, we saw at this meeting 2 other types of device, baroreceptor stimulation, also showing a lot of interest, and very interestingly, a sort of arteriovenous coupling, creating a fistula which has reduced blood pressure in some patients as well. So there's a lot of ongoing activity in devices for treating hypertension, and I'm sure we'll hear more about it in future meetings here at the ESC. Thank you for listening.